In the Public Interest, a collaborative initiative of the Committee for a Responsible Federal Budget and the Concerned Actuary Group. The following presentation has been digitally recorded, which means that you can pause it whenever you want to study one or more of the charts and graphs in the presentation, and you can share the link with a family member, friend, or associate. At the end of the presentation, you will find links to PDF copies of all charts and graphs, a bibliography related to the presentation, and further commentary by members of the Concerned Actuary Group.
Hello, I'm Mark Litto. I'm an actuary and spent most of my professional life as a principal at Milliman, one of the largest actuarial consulting firms in the United States. I specialized in the design of healthcare system and management and worked with major private corporations and governments around the world. I have retired from Milliman, but continue to consult and now serve as director at the Concerned Actuaries Group, a 501c3 nonpartisan organization of actuaries dedicated to providing policymakers, the news media, and the public with accurate and easily understood analysis of the financial realities affecting the funding and security of our nation's public finance and social insurance programs. The current national discussion about healthcare in America is not really about healthcare. It is about paying for healthcare. As a result, the dialogue is concentrated on questions related to the structure and cost of public and private insurance coverage and the subsidies related to that coverage. In this narrowly defined arena, access to coverage is portrayed or seen as a solution to the nation's healthcare needs. Policymakers, however, are not focused on how to improve the quality, availability, and management of healthcare. They are arguing instead about how many people are insured, whether people with pre-existing conditions are protected, the cost of premiums, and the level of out-of-pocket expenses. Coverage is, of course, one of the issues that must be addressed, but we cannot find the answers we seek and need by addressing coverage in a vacuum that ignores the many challenges facing our healthcare system, the demographics driving both the usage and the cost of healthcare, the economic realities related to individual and institutional ability to pay, and the economic implications of the policies currently already adopted, as well as a host of equity issues, including the shifting of costs to future generations. In short, as this two-dimensional debate rages, broader strategic and operational questions central to our healthcare needs are being ignored. Our understanding of the system is distorted, unintended adverse consequences are obscured, and we are encouraged to ignore important actuarial, economic, and accounting principles. In an effort to enhance public awareness and understanding, the Concerned Actuaries Group and the Committee for a Responsible Federal Budget, both nonpartisan 501c3 organizations, are co-hosting a series of expert presentations and conversations on the broader and more complex spectrum of issues that must be considered in the search for an equitable, sustainable American healthcare system.
The series, In the Public Interest, A Look at American Healthcare in 2017, will begin with an examination of the dynamic interaction between national demographics and finances and American healthcare. The first program will feature presentations by Mr. Mark Litto, a former principal of Milliman, Inc., one of the nation's largest actuarial consulting firms, and Mr. Mark Goldwein, Senior Vice President and Senior Policy Director of the Committee for a Responsible Federal Budget. Mr. Litto will examine three specific strategic concerns, including big numbers, the interaction between population demographics and the actual cost of care, and the impact of government on the payment for and delivery of health care. Big benefits, the relationships between benefits, usage, and costs, and who pays, the allocation and management of public and private costs and payments. Mr. Goldwein will discuss the impact of all of that on the federal budget and the national deficits and debt. In all of these presentations, we will highlight the conclusions we think critical to inform discussion of healthcare in America and share examples of the data and research findings that support those conclusions. In this big numbers segment of the program, for example, we think it is critical to recognize the magnitude of the numbers involved in American healthcare and understand how that magnitude affects both the nation's physical and financial health. To that end, we will be talking about 5 major research-driven database conclusions, including: first, healthcare cost numbers are really big and represent a very large percentage of the U.S. economy, household budgets, and federal government expenditures. Second, current growth projections indicate that without any changes, future healthcare spending will require a significantly larger and arguably unmanageable share of both individual household and government budgets. Third, the complexity of managing American healthcare is exacerbated by the large number of people affected and by the way in which they interact with the system as beneficiaries, taxpayers, and consumers. Fourth, the options being considered for changing the Affordable Care Act do not currently adequately address the needs, complexity of, or financial stability required by the American healthcare system. And fifth, the country cannot find the answers we seek and need without considering the demographics driving both the usage and the cost of healthcare, the economic realities related to individual and institutional ability to pay, the economic implications of policies currently already adopted, and a host of equity issues, including the shifting of costs to future generations. With that in mind, let's begin by noting that all the numbers we will be talking about are really big numbers. We all get that $1,000 is $1,000, and we can imagine $1 million. But $1 billion is hard for most of us to envision, and $1 trillion is almost impossible for us to grasp, which is why we want to begin by putting these numbers in context. Think about it in the way most of us think about our household bills. Suppose, for example, that you owed $1 million, won the lottery, and could pay it all off in one day. You'd be debt-free this year, immediately. Now suppose instead you owed $1 billion. At $1 million a day, it would take you a little longer, 1,000 days to be exact, so you'd be debt-free sometime in 2020. Now suppose instead you owed $1 trillion. At $1 million a day, it would take you 1 million days to pay off that debt, which means you'd be making that final payment sometime in the year 4757, or roughly 2,740 years from now. And that doesn't recognize any interest costs, which we'll address later when discussing the national debt. In 2017, citizens, employers, and governments will spend more than $3.5 trillion of their family wealth, corporate income, and taxpayer dollars on health care. That makes healthcare expenditures about 18% of the entire gross domestic product of the nation. And if we spread that number across the entire U.S. population of 326 million plus, we discover that's an average of nearly $11,000 per person in the country. Now, obviously, no single amount applies to every man, woman, and child, and widely different amounts apply to different groups depending upon age, health status, economic status, and other factors. And we'll be talking about that in the next segment of this program. For now, let's take a look at the conclusion that the magnitude of the numbers and current growth projections indicate that without any changes, future healthcare spending will require a significantly larger and arguably unmanageable share of both individual household and government budgets. And let's start by pointing out that these are numbers that affect all of us. Consider, for example, that the Bureau of Labor Statistics reports that in 2016, average household healthcare expenditures were just over $4,600, which would suggest that healthcare expenditures are the 6th most expensive item in our budgets, behind housing, taxes, transportation, food, and personal insurance, pensions. The truth, however, is that when all consumer costs are calculated, average households across the country spend more on health care than on anything else, including housing and taxes. These Bureau of Labor Statistics only count a household's out-of-pocket health care costs. A large chunk of the taxes column goes to health care to pay for Medicare, Medicaid, and the Affordable Care Act. In addition, the money that employers pay for health care, which is really both earned and paid by the employees in their household, since it's part of their pay package, is not reflected in these Bureau of Labor Statistic numbers. A better way to measure average health care spending is to simply take the average health care costs of almost $11,000 per person and multiply it by the average number of people per household, which in the BLS study is 2.5 people per household. Average household spending in total, then, is really nearly $27,000, making it the largest household expenditure. With our household budgets in mind, let's take a look at our national budget. These 2017 budget allocations are approximate, but as you can see, Medicare expenditures and Medicaid expenditures rank third and fourth in total expenditures. If we combine the two, healthcare expenditures rank number one and account for more than one of every four federal dollars spent. These already big numbers are projected to grow even larger, which raises questions about what such growth means for personal and governmental budgets. Rising healthcare costs are a reflection of rising enrollment in the nation's two major healthcare programs, Medicare, which primarily serves those 65 and over regardless of income, and Medicaid, which serves those in financial need. As the baby boomer generation grew older, Medicare enrollment increased 31% between 2008 and 2017. Medicaid enrollment increased 54% during the same time frame, for a combined increase of more than 40 million people, all of which raised public health care costs by more than $448 billion, or 60% over the past decade. These costs, combined with estimated increase in private expenditures, are projected to grow even faster over the next decade, producing a 71% increase in spending, or an additional $1.4 trillion a year. It is these large numbers of people affected, both as beneficiaries and as taxpayers and consumers, that make healthcare reform a very difficult process. Let's start with the fact that both the enrollment numbers and the financial numbers are so large that any change in benefits, pricing, or usage will have a massive impact on the population as a whole and on governmental and private sector budgets. Do the math. Take the 59 million people enrolled in Medicare, add the 74 million enrolled in Medicaid, and subtract out 11 million dual eligibles, and you're at 122 million people covered by those two programs. Add the 176 million people with private insurance plans, and you're talking about 298 million people whose interaction with the healthcare system can and does affect the cost of healthcare in America. Suppose, for example, the cost of paper, or aspirins, or electricity, or Band-Aids goes up by just $1 per person. The volume turns that $1 per unit cost into more than $250 million system cost. And the question then, of course, becomes not only who pays for these increases, but also, since most people aren't sitting on piles of money, how do they pay for it, and more specifically, what expenditures do they cut to pay for it? As we think about that, let's take another look at consumer spending. Note that fixed and essential costs, such as taxes, housing, and pensions, non-health insurance, claim roughly 59% of average household income. Healthcare expenditures make up about 9%. So where does that leave this median household as costs start to rise? Well, let's assume inflation goes up 2%, and that there is a 20% increase in premium and out-of-pocket costs, which would put our non-fixed costs at 45% of our annual income. But since our fixed costs are still claiming 59% of that annual median income, someone is going to have to explain to us and to these median household consumers what they are going to cut to come up with $1,467 that they'll need to make ends meet. To put this in some perspective, in early 2017, the Kaiser Family Foundation polled the 29% of American households who said they or a member of their household had problems paying medical bills in the past 12 months. Here are the kinds of things those households have to do to make ends meet. They cut spending, postpone vacations, postpone medical care, use their savings, and increase debt. And once again, we're talking about big numbers here. Median income means that half of the population would be 163 million plus, which in turn, assuming 2.5 people per household, there would be 65 million plus households making $55,539 or less who need to come up with more money or additional subsidies to cover health care related costs, along with millions of others who will need to come up with more than they are currently spending. We've shown it somewhat arbitrarily as a population of 65 million plus households with three different levels of added expenses, and the number, which we consider conservative, is 59 billion plus that households, people, making $55,539 or less would have to pony up to make ends meet. The same problem and even larger numbers touch the federal budget, where projected increases will increase healthcare spending from 28% to 30% of federal expenditures, adding 2% or $80 billion to the $4 trillion federal budget, and that's just for 2018. These massive numbers underscore the size of the issue, but tend to cloud the complexity of the challenges, which may explain why the options being considered for changing the Affordable Care Act do not adequately address the needs, complexity of, or financial stability required by American health care. Consider, for example, the different types of consumers and needs we expect our healthcare system to address. We have populations diversified by age, gender, and ethnicity, populations affected by being urban, suburban, or rural, and we distinguish populations as being covered by different sorts of payers and insurance or welfare mechanisms. And all of these differentiations are further complicated by the type of usage or challenge requiring attention. Just by way of example, we know that in 2011, people over 80 represented 24% of the Medicare population, but accounted for 33% of all Medicare spending. So out of that year's $375 billion, care for people over 80 cost approximately $33 billion more than a simple Medicare per capita payment would have provided. We also know that rural residents have a life expectancy of roughly 2 years less than those living in urban areas. Why is that? And what does that mean in terms of cost or lost opportunities? The size of the numbers involved and the complexity of the demands being placed on the healthcare system make clear that the options being considered for changing the Affordable Care Act do not adequately address the needs, complexity of, or financial stability required by American healthcare. We can see the complexities and the cost, but when we look at the options being proposed, we see limited adjustments that revolve around, on the one hand, more or less benefits being discussed in the context of restricting or expanding subsidies, and on the other hand, a debate over increasing or decreasing taxes or increasing or decreasing deficits. This limited definition of the issues focuses the discussion on an artificially narrow debate over federal and to a lesser degree state budgets and deficits, rather than on a broader discussion of what is working and what's not working and how to achieve the financial and managerial discipline required to support a sustainable, equitable healthcare system. Achieving that financial and managerial discipline is essential because the numbers have grown so big that they now clearly threaten our ability to provide adequate funding for other governmental and private economy needs. Consider, for example, that in 2017, healthcare expenditures account for 26% of the entire federal budget. Consider also that these healthcare expenditures are projected to grow by more than $1.4 trillion over the next decade. And now ask yourself, what happens to the federal budget if healthcare expenditures grow at these rates while everything else grows at 2% a year? Defense spending slips from 16% to 13%. Social Security could slip from 24 to 20%. If nothing else changes, unchecked growth in Medicare and Medicaid health expenditures would require 38% of the federal budget, which would require increasing the size of the federal budget and probably raising the national debt. And just to underscore how increases in healthcare costs might impact federal budgeting, consider this fact. In 2027, 65% of the $1.6 trillion added by the cumulative inflation accrued between 2017 and 2027 to that year's federal budget would be claimed by healthcare expenditures. Now look at the relationship between all healthcare expenditures and the gross domestic product. With current spending at $3.5 trillion, healthcare expenditures account for 18% of gross domestic product. Once again, ask yourself what happens if the current growth in healthcare expenditures increases by the projected 71%. Assume also, for the sake of argument, that the national GDP increases by 2% a year between 2017 and 2026. If both of those projections occurred, healthcare would account not for 18%, but for 24% of the national GDP, shrinking other consumer spending by roughly $2.2 trillion. And of course, it would increase the per capita cost of healthcare in America. Finally, at the risk of being accused of overkill, we should not forget that all of these big healthcare numbers we have been talking about are likely to increase the national debt. That debt stood at $5.8 trillion in 2001. As a result of budget deficits, driven in part by growing healthcare costs, the national debt grew by another $10.1 trillion between 2002 and 2017. And the interest on the money we borrowed to fund those budget deficits added yet another $5.3 trillion to what is now a total national debt in excess of $21 trillion, a staggeringly large number that amounts to a debt of more than $64,000 per American citizen.
The key takeaways from all of these big numbers and complex issues is, first, that we are facing large, significant problems, and second, that we cannot solve these massive problems and healthcare challenges just by moving the decimal points, zeros, and dollar signs in the federal or state budgets up or down and around and every now and then. Rather, we need systemic solutions that recognize and address the challenges in a far more holistic fashion. So solutions that are minimum based on a fair assessment of need, appropriate incentives, and fiscal capacity. Thank you for your interest and attention to this important set of issues. We encourage you to watch all 3 segments of the program, including the next installment, Big Benefits.